Hi, my name is Dr. Veeravich Jaruvongvanich. I am a third-year GI fellow at the Mayo Clinic, Rochester, Minnesota. We are excited to talk about our project today entitled Endoscopic Full Thickness Suturing plus argon plasma coagulation or APC versus APC alone for weight regain after gastric bypass, a systematic review and meta-analysis. I'm here with my mentor today, Dr. Dayyeh.
Thank you, Pete. My name is Barham. I am a professor of medicine and the director of advanced endoscopy and bariatric and metabolic endoscopy at the Mayo Clinic in Rochester. We're excited to share with you the study that we just mentioned about the role of TOR-E or transoral reduction of the gastroduodenal stoma after OI gastric bypass surgery for management of weight regain. So, as we know, obesity have reached a global pandemic proportions, and bariatric surgeries numbers are on the increase globally, with OI gastric bypass being one of the common bariatric interventions or bariatric surgical interventions performed. Unfortunately, there's a significant percentage of patients who will regain weight after gastric bypass surgery over the long term. And the reasons for weight regains are multifactorial, but they do include some anatomical factors like the dilation in the gastroduodenal stoma, which is the connection between the gastric pouch and the small intestine or the rulum, which give patients a decreased sensation of restriction and allow them to eat bigger meals, and it's quite frustrating for the patients when they deal with this weight regain. Treatment options for the weight regains have been limited, and surgical revisions and distalization of the rulum could be options. However, there are more invasive options. So therefore, we decided to look at the available endoscopic options for the management of weight regain, which include the use of APC to treat the gastroduodenal anastomosis, or the use of APC plus full thickness suturing to reduce the size of the stoma and the outlet of the pouch for management of weight regain, or at least for stabilization of the weight regain. So there has been many publications in this field, and the optimal algorithm has not been defined yet. Hence, we opted to pursue the systematic, comprehensive review of the literature and to put it together in a meta-analysis and a meta-regression approach and present to you our distillation of our findings. Pete, what's the major findings in this systematic review and meta-analysis?
Yeah, so in our meta-analysis, we included a total of 16 studies of about 800 patients in each group. And in both techniques, they are able to induce successful weight loss at 6 months and 12 months, and also halt the weight regain. However, the APMC TORI group has a higher risk of inducing stricture. And at 12 months, the APMC TORI group induces about 3.7% greater weight loss than the full thickness group. However, this could be confounded by the multiple sessions required in the APC TORI group as compared to the full thickness group, which mostly done as a one-session treatment in most studies. Interestingly, our study also did a meta-regression, and we found that greater change in the gastrointestinal diameter after the procedure, also a smaller gastrointestinal diameter after TORI, are correlated with greater weight loss as well.
Interesting finding, Pete. So what you're saying is both endoscopic management option, whether the use of APC alone or combining APC with full thickness suturing, halt the weight regain and result in a meaningful weight loss at 6 and 12 months with good safety profiles for both. But there's slight advantage of the APC approach in the long term, probably because of excess scarring. This advantage equated to something like 3.7% total body weight loss difference between the two groups. And it's not clear at this point because we're not really comparing apples to apples, because the APC alone group required up to 3 sessions of treatment with APC compared to the 1 session of APC plus suturing. So I think these are important differences to discuss. Have you noticed any baseline differences between the group as far as the diameter of the stoma or the gastroduodenal stoma when you at baseline, or they both were equivalent at baseline?
Both were not significantly different at baseline in our meta-analysis. And with these findings, Dr. Dayyeh, how would you approach in your clinical practice then?
It's very interesting findings, and I think these are opening the horizon for expanding the toolbox for management of this weight regain. So I was very happy to see these findings that both techniques seems to be effective and safe for patients. How would I approach this? The question is endoscopy is a limitation, or the cost of endoscopy limitation, or the cost of the suturing device the limitation? In setting where the cost of endoscopy is a limitation, like in the Western world, probably it makes sense to start with a one-time procedure rather than requiring multiple interventions. So the suturing and APC seems to be a good approach. However, if the cost of endoscopy is not the issue and access to a suturing device is the limitation, then using the APC approach for sure is a reasonable approach in these settings. Additionally, I think we could start now selecting patients. So probably if you have somebody with a smaller stoma, and this stoma is less than 20 millimeters, probably it makes sense to start with an APC approach, because you're trying to get it close to about 10 millimeters. So APC could get you there with 1 or 2 sessions. If you're starting with somebody with larger stomas, with, let's say, diameter of 30 millimeters or 25 or 30 millimeters, then I think this could predict the requirement for multiple APC sessions to reach to that goal, and starting with APC plus suturing with a one-time procedure would make sense. So I think we could start personalizing these choices, but the good thing is both interventions seems to be effective and safe for patients.
Yeah, thank you so much. Yeah.
Thank you. With that, we conclude, and thank you for your interest in our papers, and we're happy to answer any questions by email.
Thank you.